welcome. My name is Dr. Kelly Cleary. I'm FAIR's Senior Director of Education and Support Programs, and I'll be your moderator for today's webinar. So without further ado, let's get on to today's webinar presentation. Today's presentation is being recorded and will be available on FAIR's Food Allergy Academy and on FAIR's YouTube channel within 1 week of today. To maintain a quality recording, all of our attendees are muted through the webinar, but we really welcome you to put your questions into the Q&A. We will answer them. We've got staff behind the scenes working diligently to answer these questions. I will say one caveat, we cannot really answer very personalized questions because without knowing the full breadth of individual medical details, it's hard to give that info. But we are happy to really answer many of the questions that are in the Q&A and have a wonderful panel behind the scenes working hard. And at the close of the webinar, we are going to be giving you a link to a survey, and we would love to know how you feel like we did. So anything that you can say, we really use that information to move forward with our next set of webinars. So without further ado, today's webinar is Food Allergy Diagnosis in Primary Care, Making Sense of Food Allergy Testing. And today's webinar is sponsored by Thermo Fisher Scientific. And we are really fortunate to have two wonderful presenters with us today. So we have Rebecca Rosenberger and we have Dr. John James, both of whom have their disclosures listed on this slide. And I will hand it over to Rebecca for introductions.
Thank you, Kelly. It is a pleasure to be here with everyone today. My name is Becky Rosenberger. My background is that I have been a physician assistant for well over 20 plus years, and the majority of that time I have spent in allergy and immunology practice in New Jersey. I also direct our scientific affairs and education teams at Thermo Fisher Scientific and have a plethora of experience both in food allergy as well as allergy diagnostics across the globe. And so it's exciting to be here. I'm looking forward to sharing some of my experiences and knowledge with everyone today.
Thanks, Kelly and Becky, for starting us off. And thanks, everyone, for coming on. I see a lot of participants, and I see a lot of different parts of the country and even Canada. So this is very exciting. I was involved in the first webinar that we did here. My background, I'm a board certified allergy immunology specialist. I trained at the University of Tennessee Medical School, did my residency in Salt Lake City, and I did my fellowship at Johns Hopkins, and then went into academics for a few years, and then have been in Colorado since 1997, have over 30 years of experience in this field. And I'm honored to be asked by FAIR and Thermo Fisher Scientific to be a presenter here today. So our agenda today is listed here. We'll have a brief overview of food allergy. We'll then move in and describe adverse food reactions, immune reactions versus non-immune reactions, food allergy versus food intolerance, and then we'll go into some diagnostic dilemmas. We'll approach this with diagnostic testing, including whole allergens, whole food allergens, molecular component allergens, other evolving testing, provocation tests, or better known as oral food challenges, and finally, I'll mention unproven diagnostic tests at the end. So a sort of a summary, food allergies, as you all know, is a serious health problem. 32 million individuals in the United States have food allergies, 18% increase in the prevalence of food allergy over the past 2 decades. 1 in 13 children have food allergies, and 3% of these are severe, and 2.4% of children have multiple food allergies. And up to 10% of adults have food allergy now, and half of those adults develop those in adulthood. They didn't have food allergies as an infant, child, or teenager. That's a very more recent finding of interest. Before we get started, I wanted to mention that there is an over-reporting of food allergies that may promote unnecessary avoidance measures. So in the general public, about 20 to 25% of people feel like they have food allergies. But when studies have been done, well-designed studies, they found that about 8 to 10% of children have real food allergies and up to 10% of adults. So the public perception is much higher than what is seen when good histories and workups are done. So this is a big sort of flow chart. I really wanted to start here because I wanted to discuss adverse food reactions in detail. And the general umbrella term is adverse food reactions. That's any adverse clinical symptoms or signs that occur after food ingestion. So we'll break it down on the left-hand side, immune-mediated reactions, which are food allergies. So food allergy is a reaction that is mediated or brought on by a specific immune mechanism. So on the far left, you see IgE mediated. We're going to talk about these reactions. These can result in acute hives, oral allergy syndrome, and in the worst case scenario, anaphylaxis. The next box are non-IgE mediated reactions. These are food protein induced enteropathies. And many of you are familiar with FPIEs, which is food protein induced enterocolitis, has gained a lot more attention over the past decade. And so you may be familiar with that disease, and that's non-IgE mediated. Celiac disease also falls in this category. Then there's mixed IgE and non-IgE mediated reactions. Eosinophilic gastroenteritis disorders, like there can be eosinophilic esophagitis would be the most common one you may be familiar with. Also, atopic dermatitis would fall into this category. And finally, there are cell-mediated. These are delayed onset reactions. Most common are allergic contact dermatitis. So those 4 groups are immune-mediated, and they fall into the food allergy category. On the other hand, you have the non-immune mediated reactions. These are primarily food intolerances. There is not an underlying immune mechanism. It's an adverse physiological body response to food ingestion. These can be broken down into these categories. Metabolic, most commonly known example would be lactose intolerance. Pharmacologic reactions, like reactions to things we might ingest. Caffeine would be a common one. Toxic reactions, like food poisoning, a scromboid fish poison. This can happen when fish is spoiled, such as tuna, mahi-mahi, and the histamine builds up in that fish. When you ingest it, you can get symptoms that look like allergy, but they're not an immune-mediated reaction like IgE-mediated reactions. And finally, there are other or idiopathic undefined reactions. This would be, an example would be sulfite sensitivity.
And Dr. James, it can be difficult, even for the most skilled clinician like yourself, at times to tell differences in some of the symptoms amongst these. Isn't that right?
Absolutely. And I think we're going to talk about the clinical history, which is paramount in any beginning of any process when we evaluate patients. And sometimes we can start to sort these out just with the clinical history alone, and we don't have to go into doing a bunch of testing and food challenge. So Becky, that is absolutely correct. So it's important to see this whole spectrum, because some people come in and they just assume they have food allergy, but they may have a food intolerance. So that's really important.
And for our purposes today, we're really going to focus on the IgE mediated, immune mediated food reactions and food allergy.
Correct. So this cartoon will sort of go through the allergic inflammatory response, try to make it simple. So when you ingest a food, say peanut, it's broken down in the gut, and relevant proteins or small peptides have what are called the allergens, and that purple thing would represent an allergen. It interacts with specialized lymphocytes in our immune system. Here's a B cell. In the second diagram, it shows that these specialized lymphocytes can produce specific IgE antibodies that are specific for those allergenic proteins in peanut. Then these IgE antibodies become fixed to mast cells and also basophils, part of our immune system as well. And then when we have a subsequent exposure to peanut or another food allergen, those allergens then become bound to that IgE, those IgE molecules on the mast cell, they'll cross-link, and that activates that mast cell to release histamine and other mediators of the allergic inflammatory response. So this is a simple diagram just to set the stage for our talk today. So this slide summarizes what we call the big 9 food allergens, and these 9 foods account for up to 90% of food allergic reactions. There's certainly other foods, and really any food that has protein can ultimately cause a reaction, but these are the big ones that you hear about: egg, milk, peanut, tree nuts, soy, wheat, shellfish, sesame. These, I'm sure you are all familiar with these, and they're really been in the literature and the public lay literature. This slide, I really want to stress, this is so important in the diagnostic approach to food allergy. So healthcare providers, allergy specialists need to take a very detailed, comprehensive history, because the history is the single most important test to begin the process of diagnosing a food allergy and ruling out other problems like food intolerance and such. So it's imperative that we get a history of the signs and symptoms that are caused by the food ingestion, like skin symptoms, hives, GI symptoms, nausea and vomiting, respiratory symptoms, nausea, vomiting, wheezing, cough, and then anaphylaxis, which is a severe allergic reaction that can involve multiple body systems and can be life-threatening. Then there's the timing of the reaction following food ingestion. Some reactions occur immediately, within a minute. Other reactions go up to 2 hours. Most food allergy reactions are up to 2 hours. Then there are other food reactions that may be delayed up to 4 to 6 hours, like FPIEs, or food protein-induced enterocolitis. Some reactions occur with raw foods versus cooked foods. We're going to talk about that today. And then, are they reproducible? So parents come in and they say, oh, this has happened multiple times. If this happens once, maybe we don't know if it's reproducible yet, but it's real helpful to know if it is. Then treatment. What was used to treat the reaction? Antihistamines or epinephrine. That's more involved treatment for anaphylaxis. So all these things are important in the history and will help us as we progress into testing.
And I think the best way to help articulate this is really, let's talk about a patient case. So Dr. James, why don't you go ahead and introduce our first case?
Sure, Becky, here we go. So this is a 2-year-old male suffering from eczema or atopic dermatitis since early infancy. At 2-year well child check, the eczema was still present, and now there are intermittent gastrointestinal complaints like nausea and vomiting, abdominal bloating, distension. There's no clear trigger identified by the history at this point. So we'll move on, Becky.
This is really where that diagnostic dilemma comes into play. It is probably a very common case that many of you on the line may have faced in your practice, or seen patients, or you are a patient or have a child similar to this. And if you think back to what Dr. James had mentioned about history being critical, this is a case where we do have a strong history. We have symptoms, but it can be extremely difficult to put all of those pieces together. And that leads us to this diagnostic dilemma. It can lead to over-reporting of food allergies. So the most important piece here is really to use the tools that are available to you to get an appropriate diagnosis and help personalize the management for this patient. How extreme does this particular patient need to be in their avoidance? And what does that look like? So to help us do that, again, remember, history, number one most important test, we'll say, that you can do. Following that, though, utilizing some type of testing with allergens is really the next best step to help rule in or rule out what may be the cause of this patient's symptoms and the reactions. For the most part, we will talk about blood-specific IgE testing and skin prick testing. Both of these tests, to start, utilize whole allergens. So whether that be a whole peanut, birch tree, and both of these tests show sensitization. Sensitization in and of itself, though, may or may not equal clinical allergy. In order to have a true clinical allergy, you must have sensitization and symptoms upon exposure. And that's why that history is so critical. But let's take a deeper dive into some of these testing methodologies and see what the pros and cons of each of them can be.
Becky, could I interject here?
Absolutely.
This is so important what Becky said, because a lot of times we get patients coming in and that someone has done a test without any history, or they just do a panel of 100 foods and with IgE testing or IgG. We'll talk about that later. And there's really no context there. And people might be put on elimination diets and take many foods out. So it's so important. Sensitization may or may not equal clinical allergy. They have to be interpreted in light of the history and what testing is done. So critical.
Absolutely. So let's take a deeper dive into each of these. So skin prick testing. For primary care clinicians, most of you are not going to have easy access to skin prick testing, typically done in a specialist setting. There are commercially available food extracts. Sometimes there are skin tests done with fresh foods. Certainly I do this in my practice as well. Testing is highly reproducible. However, it needs to be performed and interpreted by someone that is skilled with it. One of the caveats here is how you interpret those positive results. And for an accurate skin test, you need to have a positive control and a negative control on the test, as well as the individual allergens that you are looking at. Skin prick testing can safely be performed at any age. I know certainly I have done testing on very young infants in my practice, all the way up to some elderly patients where it's indicated. Another advantage, you do get immediate answers, usually within 15 minutes of the skin test being completed. One of the downsides of skin prick testing, though, is that certain medications, especially antihistamines, can impact the results and need to be discontinued before testing. Not always the easiest thing to do for patients, so it definitely takes some preparation. Now let's talk about specific IgE blood testing. And so in a primary care setting, everyone has access to some sort of mechanism by which you can order or have blood drawn. So a little bit easier as far as primary care access, but also utilized by specialists. The blood tests are highly reproducible. And really the costs and the access to blood testing, you need to have a laboratory partner. And that is where some of the logistics come in as far as costs and how a patient can get tested. We're going to dig a little bit deeper into what an elevated result means and how you can better interpret those. As far as patient discomfort, it is a blood draw, but it's a single blood draw. No fasting is required, and there's no discontinuation of medication. So if you do have a patient that cannot stop their medications, or there's any contraindications of medications, that's not impacted by specific IgE testing. And the way you can remember that is go back to that pathophysiology slide that Dr. James showed. The first thing that happens is IgE is produced. If you're measuring specific IgE, there's not an interference with something like an antihistamine, which blocks the histamine later in the cascade.
Becky, I would also add, as I mentioned earlier about doing just big panels of IgE testing, allergists will usually specifically order their testing for skin testing or blood testing based on the history, and not just do wide panels and indiscriminate testing, again, because of the way the limitations of this testing. So that just want to put that in there too from the perspective of the allergist.
Yeah, I think the takeaway is certainly use the tools that you have accessible to you and use them appropriately.
Absolutely.
So let's take a look at specific IgE testing and what does that number, the objective result, what does it actually mean? So serum IgE testing, a elevated or positive result is anything greater than or equal to 0.1 kilounits of allergen per liter. You can see that's on the lowest side of the scale here, but results go up to 100 kilounits of allergen per liter. What does that mean? This is really an S-shaped curve. And what you can take away from this is the higher the number, the higher the probability of symptoms upon exposure. This is where the history comes in. And this is a scale that has been used for decades. But really, we're looking at what else can we deduce from a result, and are there any cutoffs? It is the number one question that I get asked by healthcare providers. What is the magic number? They all want to know that. Well, there is no magic number. But much research has been done, especially in food allergies, to say, are there numbers that we can say there is a high probability or a low probability of reaction? This certainly is dependent on the patient population. So this is one study that was done a long time ago, but certainly has a lot of credibility with it. But it was done on a select group of patients, looking at what is the 95% probability of a positive reaction for these 4 types of foods: egg, milk, peanut, fish. Remember, these are in the top 9, so important to look at them. And what's the 90% probability that a patient will not react? So you can see what the numbers are here. You don't need to memorize them. The takeaway from this is that the numbers are different for different foods. The numbers were different in this patient population. But in all of these situations, you'll notice the gray bar. So where's that 50-50 where you may be flipping a coin and say, I can try to figure this out from history and from my diagnostic test, but really putting things together and what is the way to get the highest amount of information as quickly as possible so that you can make management decisions for the patient. So everything that we've talked about up until now really focused on whole allergens. Skin prick testing essentially is only done with whole allergens, or as I mentioned, fresh skin testing to a muddled up peach that you can do a skin prick test for example. Specific IgE testing, whole allergens as well. But with the dawn of allergen components, the attempt was made to help define some more information when a patient falls into these gray areas.
Becky, I would add on this slide, this dates me a little bit, but these studies were done when I was a fellow at Johns Hopkins with Hugh Sampson. These patients all underwent oral food challenges to confirm that they had egg allergy, milk allergy, peanut. That's really important. So history, laboratory test, and then a confirmation on a food challenge. So that really adds to the validity of this testing. I just wanted to point that out too.
Absolutely. It's great to have that history, even if it dates you, Dr. James. Okay, so I really like to learn with some analogies. Allergen components can be a little difficult to comprehend. So I use this scenario: component resolved diagnostics, allergen components. Think about total cholesterol. Everyone here on the line has probably either run or had a cholesterol test run at one point. The total cholesterol number doesn't tell the whole story. Really, having that breakdown between HDL, LDL, and triglycerides, which each can tell you something different about a patient. Now you have more information. You can help treat the patients a bit more appropriately when you have that additional information. Allergen components are very similar. Whole allergen is very similar to total cholesterol. Again, whether it's blood testing or skin testing. Breaking down that whole allergen into protein components. Everything that you can eat, breathe, is made up of a soup of proteins. And those proteins can tell us different things about a patient. Which of those proteins is a patient sensitized to, and what does it mean for them? So we're going to first talk about egg and milk and what protein stability means for them. And we'll come back to our patient in just a moment. So for egg allergy, there are several studies that have been done that really saw that around 70% of patients that were sensitized to egg could tolerate baked egg. Example, muffins or cakes. What is the difference between those patients and the other 30% that could not tolerate baked egg? What that comes down to is protein components and protein stability. So in egg, there are several proteins. We're going to focus on two of them that are the most relevant. All protein components have these abbreviations, which are 3 letters, 1 letter, and a number. Some of them have common names, for example, in egg, so ovomucoid and ovalbumin. And when you have something raw egg, for example, these proteins look exactly the same, but when they are extensively heated, we will often say baked. The proteins, some of them, can become denatured or inactivated when they're extensively heated. They change shape. It has to be at a high enough heat for a long enough period of time, and they become denatured. And what that does is it changes the risk. Again, go back to that pathophysiology slide that Dr. James showed. The allergen and the IgE produced have to link in order to create the reaction. If the protein or the allergen looks different, the reaction doesn't happen. And that's the situation that happens with ovalbumin. But ovomucoid does not change shape. It doesn't matter how much you heat it. You could burn those eggs in the oven as much as you want to. Ovomucoid is not going to change. And this is the difference between those patients that can tolerate baked egg and those that can't. So let's go back to our patient, our case study that we had. So remember, 2 years old, has had eczema, definitely has symptoms, both skin symptoms and GI symptoms. Very hard to tell what could be the direct cause because this 2-year-old is eating a number of things in their diet and has eczema essentially all of the time. So is there a link? And it was very hard to tell exact cause and effect. So we did need to look at a number of different foods, including egg in this situation. And I'm going to bring you back to our decision point chart that I showed before. So we had this 2-year-old and whole allergen testing was done with specific IgE, and the result was 3.7. It basically falls at the midway point, right in that gray zone. I don't have all the answers that I need. I could proceed with an oral food challenge at this point, but I'll be honest, at that point, 2-year-olds and their parents, they were not eager to do that, but they still wanted answers. So we went ahead and ran egg component tests. So again, the whole allergen for egg weight in this patient was 3.7. And you can see ovalbumin was 3.5. But the ovomucoid was negative, less than 0.1. So go down to the chart there at the bottom. Ovalbumin is the protein component that is denatured with extensive heating, 350 degrees for at least 30 minutes, much like you would do with a muffin. It's denatured. And honestly, for these patients, getting baked egg in their diet does help them to potentially outgrow this allergy. So knowing what phenotype the patients have, which protein components they're sensitized to, and relating that back to their history becomes critical for personalized management. So we're not avoiding things that we don't need to, but we are avoiding those that are necessary. So in order to ensure, just like we talked about before, confirmatory testing, an oral food challenge to baked egg was performed in the form of muffins. The patient passed that oral food challenge. With the information that we had, we were not eager to go ahead and challenge to something like scrambled eggs, which are not heated enough to break down that ovalbumin. But it is definitely worthwhile to then reevaluate this patient a year later. Remember, he was 2 years old, and a good majority of these patients will outgrow their egg allergy if they're only sensitized to ovalbumin by the age of 5. Some of them are older, some of them are younger. So having a reevaluation in a year becomes important.
Becky, I would stress here that the food challenges should be done in a medical clinic with under supervision, because sometimes the reactions can be severe. So in a medical clinic under supervision with a healthcare provider, allergist, or a similar provider, and being able to have the capability to treat that reaction if there was anaphylaxis with epinephrine. So just wanted to stress that.
Absolutely. And I will just mention real quick, I know there were some hands raised. We do have people monitoring the chat and Q&A, and we will absolutely take questions at the end if there are any. Milk really falls into the same category similar to egg, in that there are a large percentage of patients that are sensitized to cow's milk, but they can tolerate baked milk. What differentiates those patients from those that cannot tolerate any form of milk? And again, it has to do with this denaturing of proteins and what happens when the food is extensively heated. There are different protein components for milk. I don't expect everyone to memorize these, but just know there are the stable proteins, which are not denatured by extensive heating, in this case, casein. And for milk, there are 2 proteins that are denatured when they're baked. And so if a patient is sensitized to those, often they can tolerate baked milk, and they are encouraged to do so. I will say the other takeaway here is, if you are able to confirm through testing that a patient is able to tolerate a food, please let them keep it in their diet. Let them continue to keep eating it. We don't want to take things out of patients' diets that are not necessary. So that was egg and milk. We're going to transition and talk about some other major food allergens, peanuts and tree nuts. And the story is a little bit different in these when it comes to cross-reactivity versus protein stability. So I'm going to have Dr. James introduce another case to us, and then we'll talk about cross-reactivity.
Thanks, Becky. So this is a kid with a history of eczema and acute reaction to tree nuts at age 2. Prior allergy testing revealed positive reactions to walnut, pecan, and peanut, as well as positive reactions to environmental allergens, tree pollen, grass pollen, and cat. Mom states they've never given peanut products. At age 4, he had an acute reaction to shrimp, and new allergy testing at that time revealed positive results to tree nuts, shellfish, and peanut. There was an unclear history with peanut ingestion in the past.
Again, probably a common patient that many of you have seen, even with different polysensitizations, we will call it here, a mix of food allergens and respiratory allergens. So what's the story when it comes to peanuts and tree nuts? It's important to understand with the whole allergens that they can have multiple protein families and they're present in different species. Think about a lot of plant foods that we eat and plants that grow. They have similar building blocks. So the example here is there are proteins in peanut that are almost identical to proteins that we see in birch trees. In the northeast part of the country, we have a lot of patients that are sensitized and allergic to birch trees. And birch trees have a similar protein to peanuts. So this is just one example of what we can see with cross-reactivity. A lot of studies have been done, again, looking at patients that are sensitized, whether it be in skin testing or blood testing, to that whole allergen peanut. And in one study, up to 77% of them were not at risk for a severe reaction. So when they were challenged, they passed the challenge. Does that mean that the test is wrong? Not necessarily. It actually means that the patient is sensitized to the whole allergen. But what is the difference in why they respond differently? Especially when it comes to peanuts. One of the most common food allergens, of course, an appropriate diagnosis is key. Overdiagnosis can really result in unnecessary anxiety and prohibiting of different activities for that patient. Whole allergen testing, again, blood or skin testing, has high sensitivity but lower specificity. It's a place where allergen components can help improve that specificity. Now, egg and milk had a few important proteins. Peanut has many more, but I'll walk you through them. I mentioned peanut and birch pollen, and that they have a protein that exists in each of them that looks identical. In the case of peanut, it's called RH8. It's a PR10 protein, and it's found in a lot of things that grow. There's also a protein that can be found in peach that looks identical to peanut. And then there are proteins in peanut that are only found in peanut. They're the storage proteins. RH1, 2, 3, and 6 are the ones that we talk about the most when it comes to peanut. Storage proteins are the ones that really can be associated with a severe or systemic reaction. And the cross-reactive proteins have a lower or moderate risk for reaction. So understanding what that makeup is for a given patient can help tell you why is this patient sensitized and to which protein components. So let's go back to our patient here. Again, multi-sensitized. We always want to rely on the history, but in this situation, he wasn't eating peanut. But 2 times there have been skin testing done, and he looks like he is sensitized to peanut. To look at the peanut proteins a little bit differently, we've put them here on this risk ramp. So again, I don't expect that you memorize all of these proteins. Maybe you're familiar with them. But on the left-hand side here are very cross-reactive proteins. And they're the ones that there is very minimal, if any, risk for clinical symptoms. But on your right-hand side, we have storage proteins, which have a high risk to cause systemic symptoms and reactions, and then the ones in the middle. So let's go back to our patient. We did, he had skin prick testing done, so we did follow it up with specific IgE testing to whole allergen peanut. His result was 10.3. Definitely closer to that 95% probability of a positive reaction, but still within that gray zone. And I didn't have a great history to fall back on. He did have eczema, so could he have had some exposure through his skin or the skin barrier that's been broken down? Absolutely. But we really needed more information. So going forward with allergen component testing to peanut for him was critical. You may get results back that look different. This is one example of peanut component test results. Again, whole allergen was 10.3. And then you can see the ones that we had available at the time were RH1, 2, 3, 8, and 9. He had all of them positive. But I want to call your attention to the storage proteins, especially RH2, significantly elevated. That tells me that this patient is on the right end of that risk spectrum and may very well be at risk for a systemic or severe reaction if ingesting peanut. This patient could just as easily have had a different result. And so even with that history, even with a whole allergen result, I could not predict that this is how the test results would look. An alternative could have looked like this, where all of that sensitization was really coming from RH8. Remember, that's a cross-reactive protein, looks identical to birch tree. And if you think back, he was also sensitized to environmental allergens. So it can be difficult to tell from the history and the symptoms exactly what those test results will look like. But it is part of the reason why it's very important to utilize diagnostic testing that you have available to you to help answer those questions and be able to give personalized management. Now, I mentioned tree nuts as well. If you can understand the story about peanut cross-reactivity, the tree nuts are pretty easy to digest as well. So extrapolating with many of the common tree nuts, hazelnut, walnut, Brazil nut, cashew nut, you can see where the proteins fall on this risk ramp here. Not every tree nut has every type of protein that's been discovered or that is relevant. So that's why you're going to see different ones, different numbers, but the concept is the same. Knowing what that allergen component mix looks like for a given patient can tell you what your best next steps are in that patient management. So I'm going to turn things back over to Dr. James to talk a bit more about emerging and evolving testing.
Thanks so much, Becky. We're going to try to get some questions at the end, so I may speak. I'm going to talk as quick as I can here, but cover the content. So specific IgE food allergen epitope testing. This is more an evolving testing, the potential to predict clinical outcomes by distinguishing these epitopes, which are really very at the very molecular level on the allergens associated with allergic disease and those associated with oral tolerance. So these arrays can be used, example for peanut, to evaluate sensitization to multiple allergens in peanut and evaluate sensitization to multiple allergen epitope patterns within that allergen. It requires knowledge of the amino acid sequence, those building blocks of the protein, and the allergenic epitopes that comprise that individual food. And these, again, these need to be confirmed with large cohorts of groups of well-characterized food allergy patients who have had histories, workup, and food challenge to get the best patients to confirm these studies. So moving further, that they're technically easy to perform and reproducible. It requires a small amount of patient serum. Extensive machine learning has to occur to validate the diagnostic and prognostic approaches with each food allergen. There is a peanut based epitope analysis available for commercial use, and this can provide a more accurate assessment or likelihood of an allergic reaction, predict the eliciting dose, threshold of reactivity into high, moderate, and low, and help predict, hopefully predict severity of clinical reactions. And ultimately, these could possibly be used as a surrogate for oral food challenges. I mean, that's something, as Becky mentioned earlier, a lot of families may not want to go to a food challenge and they're resistant because of the time and the chance for an anaphylactic reaction. And they can be helpful in identifying responses in patients who might be candidates for oral immunotherapy to food allergens, which is happening now and is going to continue to be a big issue going forward. This basophil testing is really something more at this point for research settings and applications, looking at a different type of mechanism. I think I'll move on from this because it's not going to be so pertinent to our talk today. But I do want to talk about food challenges. This is remains the gold standard. It's offered when there's a high likelihood of tolerating the food based on the history and other tests, so you can hopefully rule out the food allergy, get the food back in the diet. It's also used to assess its tolerance developed. It can be safe, but it must be conducted in a medical clinic because severe reactions can occur. It's a standard procedure, and preparation has to be taken, can be time consuming and needs to have, it may be resource intensive for the clinic with staff to do them and the physician or healthcare provider monitoring. And many patients still might decline oral food challenges for reasons of anxiety or fear about the procedure or lack of appreciation of benefits. So putting it all together here, we talked about all these issues in testing with getting the clinical history, detailed comprehensive history, then moving on to testing with whole allergens. This is still going to be a big part of what allergists are doing in their practice, and then doing component testing. This is what Becky covered in great detail in a great way. The evolving testing we touched on with the epitope analysis, and then when needed, doing oral food challenge. This is still going to be needed as a gold standard to rule in or rule out or determine if tolerance is developed. And in research studies, this is very important to validate patients. And then personalized management, shared decision making can be put into place based on the history, workup, etc. So briefly here on tests that are not recommended, they're not validated. Probably the most important one is food-specific IgG or IgG4 testing. This is a different immunoglobulin than IgE. And a lot of times I was in clinic and I would get patients bringing these really long, colorful reports, and I'd find that it was just IgG and there was no IgE testing. All of us make IgG antibodies to foods that we ingest. And how do we put that into a perspective with food allergy doesn't really fit for diagnosing that. And remember that diagram I showed earlier with the Ig-mediated reactions. So this is not a test you want to rely on and try to steer away from. Other unproven testing would be sublingual provocation, lymphocyte activation, applied kinesiology. These are things that I wanted you to be aware of. There are forms of testing that are not validated and not recommended. So why would you be referred? This is important. If there's a known food allergy diagnosis, we need ongoing management and follow-up of that patient. What elimination diets are important? When would follow-up? When would food challenges be recommended? When food-specific IgE is undetectable in a child with a very convincing history of an immediate top reaction, this can occur because skin testing is not 100%. There can be, there can be false negatives in a small number of people. When food-specific IgE levels indicate sensitization prior to food being introduced, and this is what Becky kind of covered in her case. Known diagnosis food allergy with increased risk for other food allergies. When infants develop moderate to severe eczema, refractory to medical management, or experiences an immediate reaction to a specific food. And then atopic families with or expecting a newborn who are interested in identifying risk for and preventing food allergies. This is a topic we can't get in today, but it's prevention of food allergy is so important, and there are many new studies here. And then children with peanut allergy, a 7% increased risk if you have an older sibling. So parents might bring that second child in to be tested. So move on to the next slide. So in summary, we've stressed the history paramount to an accurate diagnosis. Diagnostic testing, we covered all these whole allergen testing, skin testing, blood testing, component testing, evolving diagnostic testing. More and more information is going to come out in the future about this testing. Oral food challenges, still very important, and avoid those unproven and non-validated types of tests.
I really appreciate all of the information here, Dr. James, and I will just say the right patients at the right time deserve the right tests. And we certainly have them at our fingertips. I know there are lots of questions that we have here, so I will jump ahead and turn things over to Kelly to help facilitate.
Great. Thank you both. This was an excellent presentation, and I think really filled with so much information that you are right, the Q&A is exploding. So first, thank you all for coming. If you wouldn't mind filling out the survey, we have the link in the chat. So that would be really helpful in the future. But let's get to some questions, because again, there have been so many, and it's actually great reading the questions because people are really listening and asking for some clarification. And I think a lot of the questions really come down to when you have sensitization, but no clinical reactions. And there have been a lot of questions kind of honing in on that and wanting to know next steps, because there's been a lot of gray area in hearing from different allergists what to do. So really kind of trying to pick your brains in the next step. And I think that this is also kind of a summary of a lot of what you have both discussed in this whole hour, but sensitizations without clinical reactions, as experts, what would you say the next steps should be?
This is so important, Kelly. And a lot of these patients do get funneled to the allergy specialist. And if the patient is, again, if they're ingesting peanut or egg or milk and they have absolutely no symptoms, there've been no problems at all, but they have a sensitization, well, we make sure, confirm the history, and then we decide about opening up the diet again. Sometimes the families, they want to do more. So I would a lot of times go to a food challenge in the office just to confirm 100% that they are not allergic to that food. I don't want to go be doing, we talked about component testing. That can be very useful as well, but we don't have to go on and do more and more testing. I think the testing we have is good, it's reliable, and history testing, and then get the food back in the diet if we can.
Yeah, and I would add to that, I always take a walk backwards. Why was the testing done to begin with? And sometimes it really is revisiting the history, ask some different questions, asking it from a different perspective. I've definitely had situations where I've had parents saying, no, they don't eat that food at all. And you start to query a little bit more, take some extra time and find out actually they're tolerating it quite well. But maybe it's hidden in something and they didn't realize that. And again, you can produce IgE to a number of allergens, but you have to have symptoms upon exposure. And if you don't have those two factors together, it's not a clinical allergy. Sometimes you need to take that extra step and prove it with a provocation challenge, oral food challenge, but get as much information as you can and then make those choices for next steps.
Absolutely.
That was really helpful. And there were a lot of questions in the chat asking, do we know why? So why are we seeing elevated IgE and sensitizations without clinical reactions? Any thoughts there?
Well, I'll give one very common scenario. So we produce a lot of IgE or can, and so you may hear total IgE, which we didn't talk about today. Very common that patients with eczema have a high total IgE. So everything is elevated. And you have to look at that in context. So let's say someone has a high total IgE in the thousands even. A result that is 0.12 on a serum specific IgE where negative is 0.10 may not be relevant. So you really have to look at it in the context, but quite a common scenario. just because of the mechanisms of that chronic disease, even if not influenced by allergy.
And I would add too that the IgE doesn't, these types of reactions don't just occur with foods, they can occur with pollen, animal dander, dust mite, mold spores. But if you have a child or who already is atopic or allergy prone, might have atopic dermatitis, might have asthma, might have allergic rhinitis, their immune system in that regard might be making, like as Becky said, some IgE that is not relevant, but it's there. So you have to go through again, you have to work through the steps, and we don't know the exact answer, Kelly, to that question, but we certainly know that patients that are atopic make IgE, and it can be to a variety of different things, not just foods.
And this one comes up a lot, not just today, but a lot even in the past. IgE levels, and Becky, you alluded to kind of the levels. As people within this field, do you use those numbers in isolation ever to predict patterns of severity for clinical responses for patients?
You want to take that first, Becky, and then since you covered that so well in the presentation.
Sure. Well, the one thing I will say is comparing different technologies to each other, it's not apples to apples. So that's number one. And comparing patient results, so patient A to patient B, you cannot do that either, right? Just like we say, people have different pain thresholds, there are different thresholds for each individual patient. I can compare a patient's result to themselves, though. So the higher the number, the higher the probability of reaction, the larger the skin prick test, the higher the probability of a reaction for that snapshot in time. As there are multiple factors, though, that happen over time, there are situations where I will follow a number over time because, again, if that number decreases, is the patient building up tolerance, and do I approach it differently? Really great place to have a specialist involved to be able to follow those over time. I mentioned that there are situations that someone may outgrow an allergy, so we do monitor over time, but it's very important that you can't compare one patient's result to another patient's result and just from that say, I'm more allergic than you are, or vice versa.
And I would add to this, I know we're running out close to time, but like skin testing and blood testing, the size of the skin test or the level of the IgE that we talked about, the whole allergens, that does not predict severity. But the newer generations of testing, we're getting more information like the component testing and the evolving testing to hopefully find ways to predict severity of the reaction. That's really exciting and will be useful in the future.
Well, great. Thank you. Because with that, we are at the top of the hour. So thank you to Rebecca Rosenberger and to Dr. James for yet another wonderful presentation. I certainly think we all have learned a ton. And thank you all for joining us today. This was a great hour spent learning more about food allergies. And join us in 2 weeks for our next webinar. But thank you all again for joining us, and thank you again to Becky and Dr. James.
Thank you.
Thank you. Thanks, Kelly, Becky.